Bismillah ar-Rahman ar-Rahim. Today we are going to talk about the metabolic problems, metabolic acidosis and metabolic alkalosis. First, we are going to talk about metabolic acidosis. Metabolic acidosis, when we came back to the change in the pH itself, is under effect of two things: carbon dioxide, which is the respiratory problem, and the bicarbonate is the metabolic problem. So when we say metabolic acidosis, this means that there's a decrease in the bicarbonate. When we look at the bicarbonate, the relation or the causes of decrease of the bicarbonate, we have to remember certain facts. Number one, this is bicarbonate has a relation with chloride in a manner of electroneutrality. When there is increase in the bicarbonate, there is a decrease in the chloride. So bicarbonate decrease in the bicarbonate may be associated with increase in the chloride. And as in the case of vomiting, in this case, the vomiting, there is a loss of chloride and increase in the bicarbonate. In the case of diarrhea, there is a decrease in the loss of bicarbonate and a concomitant increase in the chloride. So this is the relation between the two: increase in that, decrease in that, which we call normal and Anion Gap changes. This is a very important one. So this is the relation between bicarbonate, decrease in the bicarbonate, this is an acidosis, in association with the concomitant increase in the chloride. This is a normal and Anion Gap metabolic acidosis. Another point of the relation between the bicarbonate and albumin and phosphorus, which is total weak acids. Decrease in the bicarbonate may be associated with increase in the albumin or increase in the phosphorus. This is another item. So, or the bicarbonate itself may be lost. A part of the bicarbonate in the body is lost through neutralization with acid, whether fixed acid or non-fixed acid, like lactic acid, keto acids, or other fixed acid, or like sulfuric or uric acid or phosphoric acid. So this is very important. The third part, the fifth part, which is water excess. In this case, there is some sort of delusional, or when there is a hemodilution. This is water excess. Hemodilution will lead to decrease in the bicarbonate, and therefore this will be associated with acidosis. The last part, which is wash out of carbon dioxide. Wash out of carbon dioxide is associated with decrease in the bicarbonate as compensatory, in this case, compensatory metabolic acidosis. So when we look at the bicarbonate, I have to remember the relation between bicarbonate and the chloride, bicarbonate in albumin and phosphorus, neutralization of bicarbonate, and the bicarbonate as hemodilution and hemoconcentration, and at the same time its relation to the carbon dioxide. So this is a sample what the metabolic acidosis. When we talk about metabolic acidosis, we say this metabolic acidosis with high anion gap, in which the bicarbonate is lost through neutralization with another acids like keto acid, lactic acid, or fixed acid from the renal failure, or toxins. Or sometimes this is a normal anion gap. Normal anion gap in which the increase or decrease in the bicarbonate is associated with increase in the chloride. As in case this may be due to renal or gastrointestinal tract, like in case severe diarrhea or renal tubular acidosis. So have to keep in mind. So these are the main causes for the metabolic acidosis, with the normal anion gap, that like renal tubular acidosis or severe diarrhea, or high anion gap in which an addition of acid which reacted with bicarbonate, like lactic acid, keto acids, or fixed acid from the renal failure. Look at this. This is very important to to see the relationship between the different items for the monitoring of the ABG. This is a normal anion gap metabolic acidosis. As I've mentioned before, normal anion gap metabolic acidosis is the loss of bicarbonate in the diarrhea or renal tubular acidosis. This will be associated with concomitant increase in the chloride. So this is a normal anion gap. This is a decrease in the bicarbonate with associated increase in the chloride. The two together is 130, and this is 142. The anion gap is 12. This normal anion gap metabolic acidosis decrease in the bicarbonate. Decrease in the bicarbonate in this buffer base, so for sure it will be less than 40. This is total weak acid 16, and this is 24. This is from 40. But the normal anion gap metabolic acidosis is a decrease in the bicarbonate, so they'll be less than 40. When we come to the normal and gap metabolic acidosis, this decrease in the bicarbonate was concomitant increase in the chloride. When you come to the strong iron differences, the difference between sodium and the chloride, so it will be less than 40. This is a metabolic acidosis. So the normal and gap metabolic acidosis will be associated with strong iron difference less than 40, buffer base less than 40. The strong iron gap will be normal. There is no increase in the keto acid or lactic acid. We didn't touch this column. So the strong iron gap is normal, and but the anion gap itself is normal because there's a decrease of bicarbonate was concomitant increase in the chloride, and the difference is the two. Look at the second part, which is high anion gap metabolic acidosis. This is mean the high anion gap. There is increase in the keto acid or lactic acid or fixed acid, which react with bicarbonate. So the volume or the value of the bicarbonate decrease. So there is decrease in the bicarbonate. Decrease in the bicarbonate itself, but we didn't touch chloride. So this is decrease in the bicarbonate will be associated with decrease in the buffer base below the 40. But when you come to the strong iron difference, it's a normal saline, normal sodium, and normal chloride, so the difference is normal. So in high metabolic acidosis, high anion gap metabolic acidosis, the strong iron difference is normal. It didn't give me a clue that there is a problem of the metabolic state. But here the buffer base told me that there is a decrease in the buffer base less than 40. This means that there is a metabolic acidosis due to decrease and the bicarbonate. When we come to the strong iron gap, for sure it will be the difference between strong iron differences and the buffer base. There is increase. It is more than zero because there is increase either it is due to keto acid increase in the keto acid, lactic acid, or fixed acid. So this is increased. When it comes to the anion gap, for sure the bicarbonate decrease. So the difference between sodium minus chloride and the bicarbonate will be more than 12. So this is the relation between the high anion gap metabolic acidosis with normal strong iron differences, with decreased buffer base, with high strong iron gap, and this is the relation between all of them. Then we come to the second part, which is the metabolic alkalosis. Metabolic alkalosis, for sure, this is there is an increase in the bicarbonate. When we come to increase in the bicarbonate, we will come back again to the same relationship. This bicarbonate with chloride, bicarbonate with total weak acids, bicarbonate with carbon dioxide, and here we will add some other things. We'll look at this. This is a high bicarbonate. High bicarbonate an relation to chloride. Decrease in the chloride in the normal anion gap, there will be high bicarbonate. This is which will occur through the kidney and gastrointestinal tract. So there's a decreased hypochloremia will be associated with metabolic alcohol. At the same time, hypoalbuminemia will be associated with increase in the bicarbonate. Hypophosphatemia will be associated with increase in the bicarbonate. At the same time, if there is some sort of water deficit, there is some sort of hemo concentrations, and in addition to this, under the effect of angiotensin 2 and aldosterone, so the bicarbonate, the carbonic anhydrase will be stimulated and the bicarbonate will increase. Another important thing for the bicarbonate synthesis or formation, so this is under effect of carbonic anhydrase in the kidney. Increase in the partial pressure of carbon dioxide will be associated with increase in the bicarbonate. Increase in the aldosterone will be associated with increase in the bicarbonate. Increase in the cortisol will be associated with bicarbonate. Increase in the angiotensin 2 will be associated with increase. And here some sort of hypokalemia. This will be associated with increase in the bicarbonate. Because in the hypokalemia, will be associated with increase in the bicarbonate. So I have to know this important point when we talk about the hypo in metabolic alkalosis or increase in the bicarbonate. For bicarbonate, this is the relation between bicarbonate and chloride, bicarbonate total weak acids, bicarbonate in relation to the partial pressure of carbon dioxide, aldosterone, cortisol, angiotensin 2, hypoalbuminemia, and in addition to these, the water deficit or heme concentrations. So these are the causes. Maybe, as we have mentioned before, maybe metabolic alkalosis may be due primary, as we have mentioned before, or secondary response to chronic respiratory acidosis, like in COPD. Carbon dioxide is increased. This will be associated with concomitant increase in the bicarbonate, which is metabolic respiratory, which is metabolic alkalosis as a compensation to respiratory acidosis. These are the main source of bicarbonate, as you know. This is the kidney from the carbonic anhydrase under influence of different items I have mentioned, or the liver, which is responsible for the formations of lactate or keto acids back to bicarbonate, or exogenous when you give the patients sodium bicarbonate. The causes of alkali, as I've mentioned before, these are the causes, and at the same time, this is common classifications. Addition to base, chloride, potassium, other disorders. You can study these, but if you remember what I've mentioned, I think you will never miss any point. Maintenance of the metabolic or persistence of metabolic alkalosis is results from the persistence of the etiology. If there is chronic chloride depletions, if there is reduced glomerular filtration rate, potassium depletions, extracellular depletions, the persistence of this will be associated with persistence of metabolic alkalosis, like nasogastric drainage, vomiting, H2 blockers, or the use of diuretics, villus adenoma with chloride loss, or chloride diarrhea with chloride loss. All of these will be associated with metabolic alkalosis. Potassium depletions, whatever the cause of potassium depletion, primary hyperaldosteronism, Cushing syndrome, secondary hyperaldosteronism, some other drugs like carboxylone or calorific diuretics or Bartter syndrome, these will be associated. So metabolic alkalosis, as mentioned before from the problem, when you look at an gap, this is maybe normal in COPD. Because COPD, there's increase in partial pressure of carbon dioxide will be associated with increase in the bicarbonate with concomitant increase in the chloride. Take care of this. Also, Anion Gap will be low in hypoalbuminemia because hypoalbuminemia will be associated with increase in the bicarbonate, and so the Anion Gap will decrease. Also, hypophosphatemia will be associated with increase in the bicarbonate. Buffer base, this is increase in the hypochromic metabolic alkalosis. And buffer base, this is a summation of the two, bicarbonate plus total weak acids. So it is increased in hypochloremic metabolic alkalosis. Hypochloremia is associated with the increase in the bicarbonate, and so this is a buffer base. So this is hypochloremia, this is increase in the bicarbonate, so the buffer base will increase. Normal buffer base in the case hypoalbuminemia, hypophosphatemia is associated with concomitant increase in the bicarbonate, so the two together will be the same 40, so no change. Normal and hyperalbuminemia, also the same thing. Hyperalbuminemia, hypophosphatemia will be associated with concomitant increase in the bicarbonate, so the buffer base will be the same. Increase in COPD for sure, this bicarbonate will be increased on the expense of chloride, so the buffer base will increase. Decrease in high anion gap metabolic acidosis. High anion gap metabolic acidosis, this is something which reacts with the bicarbonate, so the buffer base will decrease. Strong ion differences in the metabolic alkalosis. Strong ion difference between sodium and chloride. So this is normal. So if there is hyperalbuminemia or hypophosphatemia, this is the relation with bicarbonate, no change in chloride. The high in COPD, this is the strong ion differences will be high in COPD because the sodium and the chloride decreases in the COPD. There is increase in the bicarbonate with concomitant decrease in the chloride. So the strong ion differences this case would be more than 40, which is metabolic alkalosis as a compensation of this fatty acidosis. High in hypochloremic metabolic alkalosis. This is strong and differences. High in hypochloremic. Hypochloremic, this is decrease in the chloride. For this is the difference would be high and metabolic alkalosis in hypochloremia. Hypochloremia was due to increase in the bicarbonate. High in hypernatremia, if there's some sort of hypernatremia like addition of sodium lactate or sodium acetate, sodium will increase and it will be more than increase, and the difference between sodium and chloride will be more than 40, and in this case there is a metabolic alkalosis. Treatment for sure, whether metabolic acidosis or metabolic alkalosis, treat the underlying pathology, and this is another issue. Thank you very much.